My name's Dr. Scott Fowler. I'm an OBGYN in town. I'm also the president of Holston Medical Group. Holston Medical Group has about 150 providers. We have 15 locations. If you haven't heard of us, we have about 800 employees. We've been here since 1977 or so, and we're originally started really as a grant from the Robert Woods Foundation to bring primary care to this region, and that's been our mission from the start. We're a mission-driven organization. Our main goal is to create environments where patients can receive the care they need. We know inside of Holston Medical Group that there's a lot of unmet need for care in our region. And there's some things doctors can do about it, and there's some things that we can, but we certainly have done some things that we think are important in that area. One of the things that we've done is we've built this interoperability platform along with other independent physicians in the region so that a patient has a single medical record, so to speak, as they see multiple physicians who might be in different areas. This is critical that that record be available to those doctors at the point of care. The Institute of Medicine has identified the point of care as the most important place where patients understand what they have going on with them and what they ought to do about it. So the decision making occurs at that place. Based on that sort of common record, we put together an independent group that we're using those records to build Qualubel, which you've heard of already. I'm the CEO of Qualubel, mainly because this is, along with State of Franklin, Mountain Region Medical Care LLC, the larger independent medical groups, this is our effort to actually address the critical healthcare issue that's in front of us. And that issue is we have an expanding group of patients who need care and no money to pay for it. So we don't expect the hospital merger to solve all the problems that are out there. I applaud everyone, the YMCA, everybody who's investing as a community. We need to bring the community together so that we have a common interface with the patient at the point of care. We're very concerned that the merger is a distraction, quite frankly. And I don't mean in a positive or negative thing for the hospitals and the local community. Very important. We want local community. We think healthcare is local. We'd love to have a system where we have the things that we need produced and developed and available locally. There's very hard decisions that have to be made. We really need to decide as a community how we want to spend very limited resources. So it worries me that the hospital may spend $100 million consolidating IT systems into something that creates internal to the hospital, I suppose, some sort of commonality that allows them to function, but doesn't address interoperability issues outside. Right now, and the key point I guess I can make in addition to what everybody else has made is we could reduce the cost of healthcare in our community significantly if we had more power to control some of the facility-related cost structure. Currently, we have almost none. We have none in the inpatient side. In the outpatient surgery center side, we participate, but as minority members. We don't set contract rates, we don't do that. We're prohibited by the CONs from having any significant competitive advantage in those, or competitive place in those marketplaces. So I would say an index issue has to say that the healthcare system itself cannot use its ability to borrow money or the fact that it's got already an almost $2 billion revenue system in to create vertical markets in the vertical market, the surgery center market, the diagnostic center market, sleep center market, birthing center market, everything that just got opposed and beat down on the CON law, which we tried to get through. I believe both hospitals objected to changes in the CIN law. So I do believe this committee has to look at that. We can bring lower cost, higher quality care. We're doing it in the ACO. You heard we're in the top 10. We can do it wherever we have data and providers together with patients at that interface. We can improve care in the region. So I worry that the merger could impact that. We're for it in the sense that we like the local idea, but we worry about that too because we don't know what happens if another system wants to come in the marketplace to compete. You heard what happens if they do better and they want to sell. Those systems actually could probably do most of what they want to do without merging. So those are the issues and the questions we have and that we'd like to see index points on. Thank you. Yep.
I have one point of clarity. I want to make sure we understand. When you talk about
Okay, so, yeah, so the way the system is operating is that you can actually, if you improve care and you lower cost, you get to share some of that savings, okay? So if we had control, let's say, of an outpatient surgery center's contracting model, right now, a knee replacement or hip replacement is about a $28,000 to $32,000 cost if you use either one of the systems we have here. The unilateral knee can easily be done in an outpatient surgery center, and it can certainly be done for less money. 30 days all in almost every country in the world costs about $8,000. That's how far off we are in what it costs in the United States. These are standard hip replacement surgeries that are done all over the world. There's a significant delta there. We believe we could offer that surgery in a surgery center for more like $10,000 instead of $38,000. If we had control over that contracting, we might actually do that. The doctor's fee is irrelevant. It's a tiny little part of the overall cost. The real fee that gets charged there is that Part A fee that comes out of the hospital. So if it's a Part A contract and a Part A outpatient, even if it's outpatient center, then that cost is relatively high. In Qualable, where we have an MSSP contract with CMS, we share 50% of every dollar saved. So we could reduce cost, we could create more employment opportunity for ourselves and provide better care at the same time if we controlled some of those entities. That's why, for us, the CON law almost has to go away in the outpatient marketplace for this COPA to make a lot of sense to us.
Okay, so I would thank you for that answer. And your comment again on the CON. So are you suggesting the state is the other one, a CON-free zone in the MSA area?
I believe that would be fine. That would allow competitors to decide whether to invest in these services on an outpatient basis. It would open up the contracting so we could provide those services. Let's say an Eastman patient has a $5,000 deductible and they're going to have a hysterectomy. They go to the hospital, that's maybe a $12,000 charge. They pay their $5,000 and Eastman pays the rest, or pay it through their TPA Cigna. We could do that all in, anesthesia, outpatient surgery, everything for probably $5,000, and it's being done all over the country. That reduces the cost to Eastman, it reduces the cost of the patient. Eastman probably pick it up, it'd be a no deductible. So these are things that can happen and they are happening. They're things we want to do. We don't want to destroy the hospitals. They're very important to us. We understand that this merger could have real benefit from the sort of local aspects of medicine, but that's the example I would give.
I'm Gary Mabry. I'm the president CEO of the Johnson City, Jonesboro, Washington County Area Chamber of Commerce, and want to thank you for the work you're doing to cause the discussion to be as lively as it is tonight and as has been in other places. It took our chamber a while to decide where we wanted to be on the merger, and I want to share with you a handful of the framework that our members thought. Particularly, I've worked for 47 directors on 2 different boards for the Chamber of Commerce, and part of our list included things like the repurposing of dollars, the new research opportunities that would come, investment in addiction and behavioral services, improved recruitment. And I can't say enough about the recruitment piece, because we know, looking at our Academic Health Science Center at East Tennessee State University, you know, we recruit a doc, he or she wants to research, he or she wants to teach, and then we are able to address some of those much needed healthcare delivery services that we need for our patients and our citizens. Opportunities to solve health problems in the region, resulting in an area economic development benefit. I sell this region. When folks want to come here, the first question they ask, other than schools or whatever, is how's our health care? I'm living proof that health care is good, because several of these folks who've talked tonight have been practicing on me, and thank you, and I appreciate the practice that they've been doing. I think it'll be, our guys around the board decided that this would be a system that could be competitive, that we would be proud of it. Community health will improve. We feel, and I'm painting the broad strokes, community health will improve as it relates to how we use existing services, how we use the university in all aspects of higher education. Access, the thing that I heard the most is, you know, our physicians will be able to practice across the various lines. I've been around a while. I've been here for over 20 years, and I've seen, where some physicians can only practice here and other physicians can only practice there, and access by the physicians and access by the patients where they seek to. The regional health exchange, let's face it, we are a region. We're Northeast Tennessee, we're Southwest Virginia. I won't mention Western North Carolina, but there are 51 counties that are in this macro metropolitan area that we call Northeast Tennessee, Southwest Virginia, Western North Carolina. Expanding of mental health programs, addictive services. I have sat on the Frontier Health Board for a number of years. It has been refreshing as a member of one of the committees to hear how the discussion has generated and moved to where we're talking about that form of treatment and that form of health care. Let's talk about the university a minute. We have a medical school, we have a college of pharmacy, we have a Department of Public Health, College of Public Health. It's the only academic health science center that's equal to ours in Northeast Tennessee is the Ohio State University. So we're quite excited to think that we can recruit the best, serve the best, take care of our patients, take care of our citizens, and then, as you've heard, maybe get into those preventative services that we really need. Maybe we need to spend those dollars and time so that when we recruit, an industry or business will say, I want to go to Northeast Tennessee. Why? Because they're healthy. They can come to work. They've addressed their obesity. They've addressed these things that maybe other places haven't addressed as much. In short, our chamber supported this merger. The other business organizations in the region worked together to support the merger. I'm only speaking for our chamber, but I think the business community in general spent a lot of time. We did our due diligence as well, and we appreciate what you're going to do to enhance what we're going to be doing around here for a long time in Northeast Tennessee and Southwest Virginia. The people piece, the people quotient, we were concerned about that, but we think that we will be able to attract good folks. We'll be able to enhance the team that's in place. We'll be able to combine the best of each organization's workforce and service area, and we will become a top health community again and again and again, and we'll be competitive. And then we'll be able to market ourselves as the healthy Northeast Tennessee, Southwest Virginia, based on some of the things we know where our statistics aren't as vibrant or as much as we would like. So thank you for that opportunity to speak today. Appreciate what you're doing. Looking forward to the results and your report.
So my name is Wesley Combs. I run One Partner Health Information Exchange, which is local here in the region. I'm from Rogersville, so I grew up here, spent 37 years of my life here. I have 2 kids, both born in Holston Valley Hospital. I have a 92-year-old grandpa that also lives in the region. So my roots are kind of in this region itself. So we have One Partner Health Information Exchange is who I'm kind of speaking for tonight, which what it is a technology company that allows physicians to share data no matter what the EMR is. Interoperability is what we do. My background is computer science. I went to East Tennessee State University. Everybody on my team did as well. So we've got a real passion for what we can provide to healthcare in the region. We're not doctors, anything like that, but we are programmers and IT talent. One Partner Health Information Exchange was started about 3 years ago. We have about 750,000 unique patient records in our system today. We do about 200,000 messages daily, so that's care events happening in our community that come into our system and are available for care providers that subscribe to the system to see those events at the point of care in real time. So a patient goes to the hospital, the next day they show up in the doctor's office. He doesn't have to ask if they actually went to the hospital. He'll see it right there in his system if he subscribes to the system. There's about 1,500 providers that subscribe to our system in the region and or provide data into it. Walmart and Mountain States are both some of those that are putting data into the system on a daily basis right now. We're pretty proud of what we've built here because the talent to build these systems is something you don't get in a small region normally. With CareSpark and the ones that before us, we had the opportunity to really learn the technologies and the protocols that allow us to share this data. And we've put a team that's pretty passionate together because most of my team has children here as well. And what we want to see is we want to see the health system in the future be able to support them in their needs going forward for the next generation. So most of the people, most of the other regions that suffer they don't have people that are passionate about it and actually want to make it work to overcome all the hurdles that the EMR vendors and or other people will put in the way. So we try to find ways around those, which has really led to our success. To date, we've put about $3.3 million into the system, and that's us as well as our supporting customers, Quaibel, State of Franklin, HMG, Mountain Region. We've had quite a large investment put into that system and had to fight quite a few battles to get the data flowing to where we can actually share that with the providers for patient care. We support Quaibel, which was the one of the top performing ACOs in the country. They actually use our system on a daily basis, and we want to keep it that way. So we provide them with real-time data viewable at the point of care, and as well as the ability to do analytics on that data for population health management. We're trying to help them manage the chronic conditions and keep those out of the hospital and in the ambulatory space as well, where the cost is cheaper. So with some of these investments we've actually made, and some of the goal of one part, and there's a few things related to the index that we would actually like to see in there. We would like to require the new health system to participate in data sharing, no matter what system they use. We'd actually like it, even if they don't merge, to fully participate in data sharing. Through one partner, HIA, and to continue to maximize the investments that have already been made regionally with great success. The index must include measures to track the following subjects: how well the applicant leverages the existing community investment in the HIE. We would hate to see what we've built, and is actually a nationwide model that people are looking to us to implement in other regions. We would hate to see that gone in our region and not fully leveraged and maximized. Hospital data is critically important to the index, and the index must include specific data sets. And those are, the encounters when patients show up to the hospital, the labs, the medications, the immunizations, the notes. All those metrics and all those pieces of data need to flow discreetly over to the HIE on a continuous and a really open basis to make this work. That's part of population health, is having all the data to actually know where to focus your efforts within the community. We need this to be available to independent providers, not just for the patient care, but also for meeting what their metrics are in their value-based contracts, because that's what we're all actually trying to get to here, and that's what CMS is driving towards. Is 85% of the payments tied to a value or quality contract. The index must also require the new health system to provide cost data back over to the treating providers and patients, so that patients can make the informed decisions about their care. And the index must also include the actual value of dollars spent by the applicant for the health information exchange, excluding their internal costs. So what they pay out in the community for support of that system versus just replacing their internal systems. Thank you.
Just a second, any questions?
One of the, complexities in this type of environment that people live in here is our doctors in general, we know at least 28 different EHRs. Now, this has been a problem basically throughout the country, trying to find a way that different EHRs to communicate with each other. And it's my understanding that one partner has basically found a way to enable diverse EHRs to communicate to each other. So doctors don't have to chuck the system that they've learned.
Right.
Start over with a new one, invest hundreds of thousands or even more dollars in it. So could you just comment on just how unique this area is and accomplishing this?
Yeah, that's one thing we actually pride ourselves on. We originally, my staff participated in a NIN1 and NIN2 prototype. Those are National Health Information Network things by Dr. David Brailer. And where we started developing the skill set is we were set out at that point in time, and it was West Virginia. So we were sent to the hills of West Virginia to find data out of these systems that were written by somebody who hadn't touched them in 10 years probably. So we found ways around doing that, around pulling the data out, put it in a standard format, and sending it into the larger aggregating point. We still use some of those same techniques today, because the industry standard protocols that everybody's still developing are still in development. So there is no easy button for interoperability. It's hard work. And that's one thing my team prides itself in, is going out and do that hard work. And we just did one we got access to in an EMR last week that we were told, no, you can't do this, and the vendor was really pushing back. We got on the phone with the president of the EMR vendor company, and which is a physician, and he was like, why would we say no to this? Yes, here's access to the system, do what you need to interoperate. And I got a message today from one of my programmers that he finished the work already, and we'll start testing next week. So this is stuff that normally takes, anywhere from 3 to 6 months. And in a matter of 4 to 5 days, we had done most of the work for that small independent provider. I mean, it's a one-doc practice that we did that for. So.
All right.
Hello, my name is Danielle Glasscock, and I'm the Executive Director of the United Way of Greater Kingsport. On a personal note, I've had 1 child born at Indian Path and 2 at Holston Valley, so just want to share that. We are better together. In this role at United Way, I've had the privilege of working with many people and organizations in our community who are dedicated to making life better for the people living in this region. It's great seeing so many organizations, including my friends from Healthy Kingsport, the United Way of Washington County, and also Frontier Health here tonight. As you can likely tell, we are here because we want to make a difference in the lives, especially those who are low income and lack convenient access to basic services like great education and also health care. United Way believes there are 3 building blocks to a quality of life. Those are education, income, and health. Education means that our children are graduating from high school, college, and career ready. One of our biggest strategies right now is trying to help those 3rd graders read at grade level. Income means that we want families to be financially sustainable on their own, to have a living wage for which they can sustain themselves. And then health is access to good health care. We are fortunate that we have so many wonderful programs in our community that are making a real difference. We often talk at United Way about root causes, long-lasting changes to community issues, and that's what we've tried to be about at United Way. We really feel that when we can address root causes, that we can impact our whole community populations. One of those root causes that we would probably say is that when people don't have access to good health care, then they may be more likely to turn to pain medications and then become drug addicted. Drug addiction is one of the huge problems in our community, and I would like to see a metric from the combined systems on helping reduce prescription drug abuse and other drug abuse in our community. It is really impacting the lives of children and their families in our community in tremendous ways. We partner with many other great programs in our community. One, besides Frontier Health, is represented here with Terry Kidd and her great programs on mental health issues and abuse issues that they work on, is our Friends in Need Health Center. It provides affordable care to those who are uninsured and underinsured in our greater Kingsport area. And it partners with many of these organizations, Wilmot and Indian Path as well. We also try to really help children in our community with programs such as Mountain Region Speech and Hearing Center and also many other programs in our community. As we all know, missing a few days of work due to an illness can mean the difference in someone being able to afford their rent for the month or food for their family. I believe it's critically important that the new health system continues to offer charity care for those who cannot afford to pay. I believe it's also important that our access to care in rural communities be considered as you develop an index to measure the advantages the merger will provide to our area. Without these services, people in our rural communities would have to drive a significant distance to get care, making it difficult for the elderly and those without reliable transportation, and in the case last week of my niece who had a nut allergy reaction at school and had to drive 45 minutes to the nearest hospital to save lives of people that have immediate needs. 28% of our children in our area are living in poverty. We can't only just serve those children, we have to serve their parents and those families for those families to be successful. I've seen our community join together time and time again to meet a need, and I'm confident that we can work together to meet the challenges facing our area. At United Way, we often say the dollars that are raised local stay local. We've also been talking about the last couple of years, a better life for all, a better life for you. And we were very excited when the Better Together theme came out from the combined health systems. that we were really all on the same page, and that makes me think that we are on the right path for our community. I want to thank you, appreciate your work, appreciate your commitment to ensuring our uninsured and low-income friends and neighbors to continue to have access to the health care they need.
My name is Peter Platzer. I'm a family physician in Kingsport, and I'm representing an entity of one, which is me. I am a solo family physician, so I'm not representing anybody but me. I came to Kingsport 19 years ago after 20 years in the Navy. I had an opportunity in the Navy to serve in a, a variety of capacities, including running hospitals and clinics, as well as an unenviable tour in Washington, D.C., where I did officer personnel. Anybody who has ever tried to tell a doctor where to go knows exactly what I had to do. At any rate, I am here mostly to speak as a private physician, and I have to confess that I am somewhat skeptical about the merger. The merger, to me, will create a monopoly, and though it may sound great, I am very distrustful of monopolies. I would also point out that in my practice, most of my patients are also very distrustful of the merger coming down. I have basically a blue-collar practice, and there is a big suspicion of large entities. My experience with monopolies, Navy medicine was one, is that they have a tendency to, let's see, I lost my spot here. Okay, the first part is that I believe that monopolies increase costs. When there is no competition, there is no incentive to keep costs down. When the hospitals can negotiate for higher reimbursement, they can, that is going to get passed on directly to the patients. And most of my patients have difficulty with their affordable insurance now. My second perception of monopolies is that there is a tendency for them to suppress innovation. There are so many advances in modern medicine, and they come at an incredibly fast rate. But if you're a monopolistic system, then there really isn't a big incentive to get that new next best thing. Or maybe you'll put it off for a couple of years because the guy down the street, the other guy, isn't going to buy it either. The third thing is that I think monopolies suppress wages. I think the health system merger will cause jobs regardless of what anybody says. I think particularly hard hit will be Kingsport, because Kingsport is where the two big Goliaths rub against each other, and they're constantly competing, and that again is what I see. So I think that we will lose jobs not only because of consolidation of services, but I think that it will suppress the wages totally, because if you're the only game in town, you certainly don't have to offer top wages. So again, I think the competition is good. Limiting it in Kingsport will limit the choice of the patients, and I just don't have the great belief in a monopolistic system that some folks have. Thank you for the opportunity to speak.
I'm Dr. Burt Smith. I'm a physician here, independent, again, similar to Dr. Platzer. I have my own practice called Integrated Health Transitions, who I specifically focus on preventing readmissions from skilled nursing facilities, lowering infection rates, many of the quality measures that are currently included in our health reform metrics. And previously, prior to this, I started this company about 3 months ago. I worked for Mountain States. I worked with them as a hospitalist for a number of years, and so I've been kind of in and out on both sides of the fence, so to speak. And so I think I've got some important things that, as I start this new business and in this new practice, taking care of patients, things that are important as this merger goes forward that I would like to see. Many of these things have already been discussed here tonight. Some of the things specifically around IT infrastructure and things like that certainly need to be addressed. These things are things that I'm hopeful that a merger will accomplish. If we do see the merger come to fruition, that is certainly a critical area that results in a lot of avoidable readmissions to our hospitals and things like that, because we cannot access, as has been mentioned many times previously, we cannot access patient records in a timely fashion at the bedside. Another big area that's also been touched upon here this evening and talked about is mental health. There's so many things here with the mental health patients in our area, that things that result in hospitalizations and so forth, that we need to see more done in that area. For example, we've seen mental health care and access decline in our area as a result of competition. With Mountain States and Wellmont, we previously had Indian Path Pavilion that provided psychiatric care. We've seen that leave our area since then. We've seen those beds go away. We really just have Woodridge, I think, now in the area that provides mental health, and we see a lack of services there. So I would certainly want to see this COPA include things around providing more mental health. It's typically not an area that's reimbursed very well, which is why we've seen some of that access go away, and so would like to see that addressed specifically. And I know that that has been mentioned by the two systems, but again, as someone mentioned earlier, it kind of gives David a slingshot, so to speak. We need to make sure that these entities do that. And probably the third thing I'll talk about that's really important, that it was interesting to hear Dr. Platzer talk about the other side of it just a minute ago, but the clinical standardization. We don't have a lot of clinical standardization in our health systems. I helped do a lot of that when I worked with Mountain States. I felt like many times that we were sort of reinventing the wheel, so to speak, when Wellmont was also working on similar problems, but we were not allowed to collaborate or talk or help each other with those things. And so it seemed to be very frustrating to me as a physician that we had a lot of things that both of us were working on that seemed like we could really help and collaborate with each other, but weren't allowed to because of competition. And so there are some things, while I agree that competition is a good thing and will improve many aspects, there are some things that we've seen competition hurt, and we've seen competition that has eroded away at some of these aspects that I bring up here specifically tonight. So I would encourage you guys specifically, I'm glad that this is being looked at, but I would encourage you guys specifically to look at these things that I mentioned here tonight. I know many of them have been talked about, but again, there need to be some measurable things in the COPA that we can track and follow the progress of.
I am Tony Seaton. I'm not the attorney. He does a great job at advertising, but I'm actually an ophthalmologist. I'm an ophthalmologist in Kingsport at the Regional Eye Center. I've been practicing medicine in Kingsport, Tennessee now for 20 years. I am also a member of Highlands Physicians Incorporated. Highlands Physicians Incorporated is a physician organization that represents some 1,500 physicians and other practitioners in the area. I've been actively involved with the board at Highlands Physicians for all of my 20 years here, and I currently serve as the president of Highlands Physicians. Our medical community, as you've already heard here this evening, is diverse and multiple, but obviously two very important components of that are the providers and the health systems themselves. And often these are joined at the hip, and it's very important to be able to deliver a good quality care to those that we serve for both sides of that equation to work well with each other. Highlands Physicians' mission for the last 23 years has been to work to improve the quality and the value of health care in our region, and we take this very seriously. Therefore, we've watched very closely the application of the COPA and the issues regarding the discussions of the merger over the last several months. And we appreciate the opportunity to come here this evening and to bring our thoughts to this group regarding the proposed merger of the health systems, and also to suggest metrics that can be used by the Department of Health to assess whether the merger is and whether it will continue to produce a public advantage. First, I'd like to say Highlands Physicians does not oppose this merger. We can certainly see the potential advantages to the community, benefits such as theoretically exist, such as eliminating duplication of services where appropriate and where possible, cost savings by reducing redundant infrastructures, and obviously the improved buying power that can be achieved, as well as many others. But we also see potential disadvantages that we think are very important to discuss. It's already been asked how many staff positions at our facilities may be lost. How will repurposing potentially affect our community? Will the monopoly that would be produced by this potentially exclude non-employed physicians and possibly result in physician migration, which could affect long-standing physician-patient relationships also potentially loss of staff jobs in those physicians' practices. How might all of those potential issues affect the quality, the access, and as well as the value of healthcare in our region? We have met with the CEOs of both Mountain States and Wellmont to discuss our concerns and have asked that specific things be included in the COPA to hopefully help to prevent potential disadvantages as we see those. We have a great deal of respect for the CEOs of both Mountain States and Wellmont. And we have a great deal of confidence in them, but we also understand that healthcare is changing. And what may be important at this point in time, 2, 3, 5 years from now as things change, may be different. And also administrations change. And the thought processes and the goals and the concerns of future administrators may be different than the ones that we currently have. And that's why we feel that it would be very important to try to address the potential issues that we see of potential disadvantages, especially in the COPA language on the front end. With regards to metrics, we feel that they should be broad and robust. We think they need to be objective, accurate, and independently verifiable. We certainly would suggest patient satisfaction surveys in regards to quality, access, cost, and service levels. We would suggest physician satisfaction surveys, both for employed and non-employed physicians, in regards to things such as financial impact to their practices, influence over clinical decision making. Okay, thank you. Perceived unfair treatment, exclusion from contracts, disruption in patient-physician relationships, and loss of the ability to provide care and value of care to their patients. We would also suggest payer surveys, looking at various metrics that the payers may be able to introduce, and we would love to see transparency in the whole process. So in closing, again, thank you for this opportunity, and thank this group. You are true community servants to sit up here and to listen to us drone on now for hours and hours. I'm sure many of you like me without having your supper yet. But we would just like to say that we think this can be a very good thing, but we would certainly like to see potential disadvantages looked at, and potentially have these potential disadvantages looked at from an independent standpoint, not necessarily just generated from the health system itself. Thank you.
Thank you.
Yes. Yes, financial impact, influence over clinical decision making, perceived unfair treatment, exclusion from contracts, disruption of physician-patient relationships, and the ability to provide quality care and value to our patients.
Good evening. My name is Clark Jordan, and I'm Vice President and Assistant General Counsel at Eastman Chemical Company. Eastman's been part of this community since 1920. We employ over 6,000, sometimes seems like 60,000 employees in the region, and we have a very strong history of supporting the communities in which we operate. Safety and wellness are one of our key priorities as a company. As Eastman seeks to grow in the world and in this region, we must develop a diverse and inclusive workforce. Access to high-quality health care and quality educational systems are critical factors considered by those that we seek to employ. Products that Eastman produces in this region compete in a very broad, competitive global marketplace. Eastman's self-insured, meaning that we assume financial responsibility for providing health care benefits to our employees. For our products to remain competitive, we must control the health care costs that the company faces in providing the benefits that our employees and their families deserve. As we evaluated options presented for the region's health care, Eastman carefully considered which option most closely aligned with our interest of controlling health care costs, improving the quality of health care, and expanding access to health care throughout the region. We felt that it was important for the region to retain control of its fate if it was at all possible. When the prospect of the Wellmont and Mountain States merger was announced a year ago, we expressed our support, and we continue to support the merger. However, our support is conditioned upon the merging entities agreeing to firm and measurable commitments to achieve positive outcomes for the region, and proper supervision by the states of Tennessee and Virginia, and oversight through strong governance of the combined entity. We have a great deal of experience in mergers and acquisitions. I lead those on behalf of the legal department for Eastman Chemical Company. Signing the merger and closing the deal is just the beginning. The true success is determined by the integration of the combined companies. We know from our experience that cost of just doing the integration can erode the value of the two companies that are merging. So we encourage Mountain States and Wellmont to be good stewards of the resources that they may have together if this merger is to go through. Likewise, we know that the merging entities have to make choices to be sustainable for the future. And as we think about those choices, we encourage them to do it in the best interest of the community as a whole. To achieve success, the organizations have proposed a three-phase approach: an immediate reduction of 50% of all negotiated cost rate increases with principal commercial payers for the first full contract year after the merger, placing a cap on the growth of rates charged to principal commercial payers and healthcare services to below the national average growth for hospitals, and implementing population health and other initiatives designed to improve healthcare of the region. We support this approach. We believe that additional transparency and clarity will assist the community in understanding what these mean. By way of example, we believe that the two systems have current differing rates for the same or similar services. It's unclear to us if one service is rationalized, which cost will then begin to control that service. We believe additional transparency around the initial cost will assist the community in understanding what the value of the transaction will ultimately be. In my mind, this merger has the potential to be a win-win-win. Costs could potentially decrease, quality of care could increase, and those cost savings could be reinvested within the community in critical areas such as wellness, combating drug addiction, preventative medicine, and mental health care, which will benefit the region overall. Thank you. Within that same vein, the future system has committed to establish annual priorities related to quality improvement and publicly report these quality measures in an easy to understand manner. We encourage this. Again, I want to thank you for the opportunity to comment. We support the merger, but we think the devil is always in the details, and we value the input that this group will provide to ensuring that the actions of the merger and those measures within the COPA remain in the best interest of the community.
Our primary focus at this time is a family preservation contract that we hold with Department of Children's Services. So we serve hundreds of individuals a year across the Northeast region who are involved with Department of Children's Services because of child abuse or neglect. We also have a pilot program with Tennessee Department of Health that is designed to be an outreach to moms who deliver NAS babies in the Northeast region. And we also serve women and maternal incarceration, women who are affected by substance abuse and maternal incarceration. It has been a long evening. I'm just going to read from my paper now. Families Free is designed to build better communities through the transformation of vulnerable families, especially those impacted by child abuse and neglect, maternal incarceration, and substance abuse. We provide evidence-based services combined with faith-based principles, including compassion, healing, and restoration. Our goal is to promote positive lifestyle changes in our region's most at-risk and overlooked population. I was privileged to be able to serve on the Healthy Children and Families Steering Committee, And our population that we work with at Families Free was often referred to as the super utilizers of services in the region, and I'm sure that's true. In the past year, we've served more than 500 individuals. I've seen firsthand how poverty, lack of awareness or access to needed services, mental health issues, drug abuse, alcoholism, and much more can all contribute to hurting families in our community. I'm very passionate about the work we do and proud of the work we do. We all know that individuals who are healthy from a physical perspective, but also from an emotional, mental, and spiritual perspective, create healthy and strong families are the basis of strong communities. We couldn't do the work we do without our community partners, and I'm very pleased to see that Wellmont and Mountain States value the role of community partnerships, as well as the importance of investing in and promoting healthy individuals, families, and communities. Supporting our friends and neighbors who are going through difficult times or need access to certain specialized healthcare services is critical. As this advisory group considers the public advantages of the future system, I would encourage you to monitor the future system's investments in access to these kind of critical services, such as community-based mental health services, intensive outpatient treatment programs, and addiction resources. These services should all be designed to help struggling members of our community and hopefully minimize inpatient psychiatric admissions, incarceration, and other out-of-home placements, which separates families rather than keeping them together. I'm excited to see that Wellmont and Mountain States plan to invest $75 million over 10 years in population health initiatives and will prepare a healthy improvement plan that identifies key health issues to focus on. One of the initiatives already identified is to promote a drug-free community by investing in programs that prevent drug abuse among all of our citizens, but particularly among women and teenagers. My organization will do everything to support the future health system in these efforts, and I encourage this advisory group to track these kind of investments so we can see the significant progress we seek to see over time. I would really encourage each of the members to think about what our region looks like from the perspective of a vulnerable family. We have extremely high incidence of children who are placed in foster care in Northeast Tennessee. We have extremely high incident of neonatal abstinence syndrome, one of the highest in the nation, and also of maternal substance abuse, with very limited targeted resources. At Families Free, we have staff that goes all over the hills and hollows and communities, and we go and meet these individuals in their homes, in the county jails, in the hospital when they've given birth to an NAS baby, and give an evidence-based strategic approach to helping these women and families overcome the challenges in their life. So I would encourage this advisory panel to look at programs that would specifically reduce placements in foster care by children in our region, NAS babies, and maternal incarceration.
I'm Kenneth Hoplin, and I am a local fellow here from Elizabethton and a physician. Born in Wisconsin, but thankfully moved away pretty soon, and my father brought me down to Tennessee. So from age 4, raised in Elizabethton High School, ETSU, James H. Quillen, Bristol Family Practice, and from there to Medical Care, which is a local primary care provider here in Elizabethton in our local Tri-Cities, where we provide care to basically one of the poorest counties in Tennessee. So we have a high rate of dual eligible patient load, meaning they both are Medicaid and Medicare eligible, as well as a high rate of TennCare. And we're among the top 10 in the whole state of Tennessee for providing that care. So we don't provide care to the elite. I mean, blue collar even is maybe even generous. And I see it as my position that I neither need to come nor in support of nor in opposition to But I see it as my position that I need to come and point out some possible shortcomings or concerns as an independent physician who is not employed or affiliated with any hospital system or insurance company other than through contracting or otherwise. Because obviously the hospital systems know the positives. I see it as our job as independent physicians to point out what the potential negatives are to us, because the positives are obviously why they're planning on merging. So there's 3 areas of concern I see from an independent physician that immediately strike me. One is contracting, the second is through physician recruiting, and the third is physician access to hospital services for their patient load. And being a physician that practices primarily outpatient, no longer doing inpatient care, I stay focused on an outpatient basis in a lot of my thoughts, but some of these do pertain to hospital privileges and physicians who practice in the hospital as well. As far as contracting, I think that my big concern is when you have the 2 big hospital systems merging, you have the potential for bundling contracting for inpatient services with outpatient services. And I think that we need in these documents something that guards against such type of contracting practices, because contracting practices such as those provide an unfair benefit, number one, to competing non-affiliated physicians, because if there is need for hospitalization, and that can be used to create better rates both for your outpatient services, or you can discount outpatient services to achieve rates that they need for inpatient services. It provides an advantage that is really uncompensatable, and since this is done through a certificate of need, so essentially it is a government-granted monopoly, one that cannot be duplicated by any other type of entity that provides primary care other than a hospital system. And these hospital systems, when they combined, are going to be the #1 employer of physicians in the area, even when considered the larger groups in the area. I mean, you know, even excluding some of the independent physicians, a smaller group such as my own, but even the larger groups which have been spoken of, the HMG, State of Franklin, these are large groups in our area, but even they are dwarfed when you talk about combining these 2 hospital systems. And so there's a great deal of concern that if their contracting has advantages that other groups are unable to access, it really provides an unfair environment to which physicians are, I think, especially independent physicians, become very uncomfortable with very quickly. The second thing is in recruiting, and it really sparks the same type of questions. When we speak of recruiting for areas that are in need and unable or unwilling to provide, I think, first of all, there needs to be, if that is the case, there needs to be somehow a demonstrable matrix or otherwise that the non-hospital affiliated physicians are unwilling or unable to provide those services. And even if that includes some sort of a board or regulatory committee that involves non-hospital employed and non-hospital contracted physicians to state whether or not those recruiting is actually needed, or whether or not that is just being done to, frankly, just compete with the outside non-hospital associated groups. And the other way that could be done, other than a committee that might oversee recruiting that involves the other non-affiliated hospital groups, you could also possibly put in a matrix that states that once this combined organization were created, if it were created, that it not gain a significant amount of market share in the primary care or other markets. So, for example, if the merger reached 50% of the physicians in the area, that they would not exceed 55% in a certain time period, so that there wasn't a push for acquisitions or takeovers or mass hirings to promote lack of competition. And the last thing being the access to hospitalization is that once the hospitals have, there isn't any competitory hospitals, things such as hospitalist and or specialist access to hospitals that they need to take care of their patients, and hospitalists being a concern for mine, that outside independent physicians have a say if there is going to be exclusive contract given for a service within the hospital, the independent physicians be allowed to have a say as to whether or not that is an indicated move. Hospitalist as being the one that would be my primary focus, that they're not being moved to create a exclusive contract with hospitalists, so that outpatient physicians such as myself cannot choose which hospitalists I might use, which have a like-minded way of treating my patients and or a lower cost for treating my patients, which is absolutely critical.